Hi, class. My name's Paul, Professor Park, and I am going to be discussing the title of my slide presentation is called Bad Urges, and I'm talking about pedophilic disorder, and it's a clinical overview of diagnosis, etiology, and evidence-based treatment. And let me move to the next slide. Okay, so we got to talk about pedophilia. A lot of people think if you have the thought, boom, you're a pedophile, but it's not. So, pedophilic sexual interest is a trait. Pedophilic disorder is a clinical diagnosis, and they're not the same. The DSM-5 diagnoses the disorder only when urges are acted upon or cause marked distress or impairment. It sits at the intersection of psychiatry, forensic medicine, and child protection. It is among the most stigmatized conditions a clinician will assess, which suppresses help seeking. Because when it's all said and done, if you're having these urges, you're not trying to get help because it's the shame, the embarrassment, the potential for legal liability. There's just a lot you don't want to do. And then most child sexual abuse is not committed by diagnosed individuals. Treatment is a prevention tool. So, yeah, let's go to the next slide. And here's the criteria from the DSM-5. Criterion A, over at least 6 months, recurrent and intense arousal fantasies, urges, or behaviors involving prepubescent children, generally 13 or younger. Criterion B is the person has acted on these urges or they cause marked distress or interpersonal difficulty. Criterion C, the individual is at least 16 years old and at least 5 years older than the child. Ooh. Specifiers. There's exclusive versus non-exclusive type. Attraction to males, females, or both, and it's limited to incest. Clinical criteria differ from legal criteria. A crime may not meet the diagnosis and vice versa. Okay. And the next slide. Okay. Whew. So prevalence is uncertain and almost certainly underestimated. In my papers, roughly 1 to 5% of community samples of men self-report pedophilic sexual interest over their lifetime. Prevalence is estimated at up to 3% of the adult male population and substantially lower in women. Diagnosed cases occur overwhelmingly in men, over 90%. Rates in women are poorly characterized. Reports suggest roughly a 2-to-1 preference for opposite sex over same-sex children. And true prevalence is unknown. Concealment and reliance on self-report make figures orders of magnitude, not precise. So another question I had while doing this is like, why is it more prone in men than women? I've always wondered that. Like, I'm sure there's women that do it, but why is the rate so much lower? Like, is there something wrong with men? Or is there something, a gene in men that causes it? What? I was wondering about that too, because I was going through all my stuff. Okay. A neurodevelopmental sexual preference disorder. It's best understood as a neurodevelopmental sexual preference disorder, not an acquired behavioral pattern. Neuroimaging shows structural and functional differences in cortical and subcortical regions of the brain. So that's your limbic and your frontosterolateral. I think that's how you say it. I hope I spelled it right. And then you have familial and neuroendocrine hormonal factors are implicated in its development. Developmental markers include higher non-right-handedness, lower stature, and neuropsychological science. Childhood victimization may contribute for some, but no single environmental cause is sufficient. Etiology is factorial. So also, let me move my computer. Oh, I can't read my little part I want to read right here on my slide. But yeah, so when another question I had was, when does it start? Does it only happen as you get older? Or was it like, when does it start? Does it ever end? Oh, and I'll get into that later with treatment. Okay, now there's the features, subtypes, and a differential diagnosis. Exclusive types are only attracted to children. Non-exclusive types are also attracted to adults. So there it is there. There's another change, people think it's only to children, then you find out it's happening to adults too. And they specify attraction to males, females, or both. The offender is often known to the child. And we've all heard the saying, stranger danger to our kids. But it turns out most studies show that it is somebody that is known to the child. It's a family friend, a family member, or a close associate. Uh, yeah. And it also frequently overlaps with other paraphilias, hypersexuality, and personality pathology. And to differentiate from OCD, ego dystonic intrusive thoughts without arousal or any desire to act. And you can also rule out antisocial, opportunistic offending, intellectual disability, intoxication, or mania. So it's not, it's like, how would you say this? It's just not, it's not your ego pushing you to do it. Okay, let me go to my next slide. Now, here's where we start getting to how do you assess it? Assessment is structured and risk focused. So usually when you assess, you ask tons of questions to figure out the background. Well, it's no different in this. So you got to conduct a comprehensive interview covering sexual history, fantasies, urges, and behaviors. So you have to know all that. And you can't be, well, you probably will be uncomfortable asking these questions because we're human. But we also have to corroborate with collateral records given concealment and social desirability bias. And then we also got to screen for uh, comorbidity because usually there's other paraphilias involved, that mood, substance abuse, personality pathology, because all these change the way a person feels, the mood, your substance abuse. If you're using that, what if you have uh, a DID? Okay, and then just test. A static 99R provides actual relative risk of sexual recidivism from historical static factors. A stable 2007 tracks changeable dynamic risk. Acute 2007 flags short-term situational triggers. Now you got the psychological and behavioral approaches. CBT, or cognitive behavioral therapy, targets cognitive distortions and builds impulse control and self-regulation. Relapse prevention identifies high-risk situations and triggers and rehearses concrete coping plans. Acceptance and commitment therapy builds psychological flexibility, acting on values rather than urges. Group therapy and structured prevention programs reduce isolation and reinforce accountability. And a realistic goal, therapy reduces the risk of offending and eases distress. It does not eliminate the interest. Because at this time, as I do that, there is no cure for pedophilia. It's just a lot of cognitive restructuring you would have to do because you don't want to put yourself, like, right, how I said, high risk situations or triggers. if you're having problems coping. Like you're not going to go to an amusement park. You're not going to go to the park where all these triggers are there waiting to be discovered by you. But there are options, pharmacological options by intensity. SSRIs are first line for milder cases, reducing sexual preoccupation and compulsivity. Anti-androgens lower testosterone for higher risk cases because testosterone does push men. And then you have GnRH agonists give the strongest androgen suppression. Injectables reduce risk within weeks. But here's a big one. You have to monitoring is essential. Bone density, metabolic, and endocrine side effects require ongoing review. And the thing is, you can't do this just with therapy alone. You need medication works best when it's combined with therapy. Okay, now we come to confidentiality, reporting and prevention. Therapeutic confidentiality is paramount, but not absolute. We have to know its limits as clinicians. Reasonable suspicion of child abuse triggers mandated reporting in most jurisdictions. A credible identifiable threat may invoke a duty to warn or protect potential victims. Stigmas deters help seeking. Secondary prevention programs offer treatment before offending occurs. Reporting thresholds and duty to warn rules vary by region and role, and you have to look through your local statutes for that. Okay, so here are some takeaways to look at. You want to distinguish interest from the disorder. A sexual interest is a trait. The disorder requires acted upon urges or marked distress or impairment. That's like having a thought. If you don't act on the thought, though, nothing can be done. Etiology is neurodevelopmental and multifactorial. Brain, genetic, hormonal, and developmental factors converge. It's not one thing causes it. Assessment is risk focused. Combine clinical interview with structured tools using Stack 99 and Stable 2207, the acute and collateral data. That way you can get a better picture of how everything is going. And remember, treatment manages risk, not cure. Multimodal, long-term CBT, and relapse prevention with pharmacotherapy escalated for higher risk. So higher risk demands that therapy with medication be used. And then ethics frame everything. There's confidentiality limits, mandated reporting, and reducing barriers to help are essential to safe practice. So going through all that, and these are all my references. Okay, so that is how pedophilia works. And I know it's an ugly subject no one likes to talk about, but we're doing our best to help the people that need to help so less problems happen to kids. So thank you. That is my slide presentation.